Hello, my name is Dr. Thomas Roth, and I'm the director of the Sleep Disorders and Research Center at Henry Ford Hospital in Detroit, Michigan. And what I want to talk about is insomnia. And obviously, as a sleep researcher, the most prevalent sleep disorder is in fact insomnia. And I think insomnia is a very, very important topic because the medical view of insomnia over the last 25 years has dramatically shifted. And it's done a tremendous change, and that change has tremendous implications of how insomnia is treated. So if you go back about 25, 30 years, insomnia was thought of as a symptom, if you look at it in DSM-4, for example, and it was secondary to a variety of conditions. So if you had insomnia and depression, you would have seen that the main disease you have or the main disorder you have is depression. Insomnia is secondary to that. And your job as a clinician is to treat the depression, and insomnia is going to go away. If insomnia is a problem, you can use a sleep medication, but only for 7 to 10 days, and then it'll get better. Well, over time, we've learned that insomnia is a disorder. Now, why do we come to that conclusion? Well, one, it turns out when you use medications, the typical SSRIs, SNRIs, and you treat the insomnia, it doesn't go away. Two, very importantly, 9 studies, when they started looking at this, 9 studies have shown that insomnia predates depression. So insomnia is a risk factor for the development of depression. One study followed by Chang followed him over 30 years. So if you look at DSM-5 as it's evolving, the diagnosis is insomnia, and depression is a descriptor under that diagnosis. So it's very important to understand is insomnia is a disorder. It is a chronic disorder. As such, it warrants treatment. What is also important to realize, and I think this is incredibly important, is 90% of people who have insomnia have a comorbid disease. But that comorbid disease is simply because of the fact that insomnia interacts, or sleep disturbance or sleep loss interacts with many of these things. So let me tell you what I define as insomnia, what the sleep community and now the DSM-4 and 5 define as insomnia. Insomnia is a symptom of difficulty falling asleep or staying asleep or non-restorative sleep. But that's only one criteria. 2, that must be associated with some kind of impairment or distress. 3, there's a frequency and duration criteria, so it must be prevalent at least 3 times a week for at least a month. And 4, it must occur despite adequate opportunity to sleep. When you look at that symptom, what's very important, there's a significant amount of morbidity of that. We've talked about the risk of depression. There's data from Alon Avidan, there's a risk of falls. There's now more and more data coming on risk for cardiovascular disease, risk for metabolic changes such as weight gain. And most importantly, those pathologies are due to the pathophysiology of insomnia. And the pathophysiology of insomnia is a disorder of arousal. So if you look at brain metabolism, if you look at cardiovascular, if you look at autonomic nervous system, if you look at HPA output, people with insomnia are hyperaroused. Clinicians see that when the patient says, I can't shut my brain off. Well, they really can't. If you do PET scans, they can't shut their brain off. So the bottom line of all of this thing is that insomnia is a disorder, and our job is to treat that disorder as well as the comorbid condition. So if you have insomnia and depression, you treat both, and they both get better. If you have insomnia and pain, you treat both, and they both get better.